So welcome everybody to the first of our Manchester Academic Health Science Centre or MAHSC Honorary Clinical Chairs inaugural lectures. I'm Jonathan Massey and I'm the Programme Director for Academia at Health Innovation Manchester. So Academic Health Science Centres are designated by the National Institute for Health and Care Research and NHS England to university NHS partnerships that demonstrate excellence in health research, health education and patient care. We've held AHC designation in Manchester for about 15 years now, with the most recent designation in 2020 for 5 years. As part of Health Innovation Manchester, the vision of our HSC is to make new scientific discoveries and shorten the time to turn them into effective treatments that deliver benefits for patients. The MAHSC Honorary Clinical Chairs are awarded on an annual basis by the University of Manchester's Faculty of Biology, Medicine and Health Promotions Committee, and they are awarded to individuals from across the Greater Manchester health and care system who have made a major contribution to their field, including excellence in research, education and patient care. In 2022, the university welcomed 16 new honorary clinical chairs to join the group of now over 80, and I'm delighted that two of the 2022 intake, Professors Iain Lawrie and Ed Smith, are here today to give their inaugural lectures. We are planning for the other 14 honorary clinical chairs that were awarded in 2022 to have their similar lectures over the next year or so. I will first hand over to Professor Karen Kirby, who is the Professor of Proton Therapy Physics, to introduce Professor Ed Smith's lecture. We'll then pass to Professor Joe Hart, Head of Division of Medical Education in the Faculty of Biology, Medicine and Health, to introduce Professor Iain Lawrie. So Professor Kirby, over to you.
Okay, thank you. And I'm delighted to introduce my colleague, Professor Ed Smith, who's played a key role in introducing proton therapy into the UK. But there's so much more that Ed's done. As director of the Christie Proton Therapy Centre, he led the development of the service and brought it in on time and I believe below budget. So Professor Sir Mike Richards, when he visited the centre, basically commented, this is NHS Plus, and it's a truly beautiful centre with patients at its heart. But Ed did so much behind the scenes, and the Proton Clinical Outcomes Unit, which is now a national service for collating world-class proton outcomes data, which is the envy of the rest of the world, is something that he worked very hard to develop. Similarly, Ed worked tirelessly to ensure that the Proton service was a national service and that patients were referred from across the country and that national clinical trials were being developed. Through the Proton School, which he established, Ed also shares his expertise internationally. And at that point, I could tell you about that Ed graduated from Oxford, but I think it's better if you hear about it from Ed and what he's done. So at that point, I'm going to shut up and let Ed take over. Thank you.
Thanks a lot, Karen, for those kind words. And I'm honoured to be giving this inaugural lecture. I'm more than a little bit nervous, so bear with. I will just share my slides. Hopefully everybody can see those. Great. Okay, so I've titled my lecture Proton Therapy Without Knowledge, Action is Useless and Knowledge Without Action is Futile. I think a saying as relevant now as it was over 1,000 years ago or so. As well as being clinical director of the service here at the Christie, I've got some other roles which are along the bottom there. The brief for this inaugural lecture was to talk a little bit about myself, and that was probably the hardest bit about preparing for this lecture. So a little bit about me and my journey. I was born and raised in the northwest of Cumbria. It was then called Cumberland, and actually from the 1st of April this year, the old Cumberland and Westmoreland are being resurrected. I was brought up in a very, very rural area, and you can see me there in my little toy tractor and some cows in the field next to the house, which I suppose on a personal note, I'm able to milk cows, and you can see some days out there in the Lake District with my family. I went to school in a place called Wigton, which was a comprehensive school with grammar aspirations. Interestingly, William Bragg also was born in Wigton, so there's a bit of a link there to protons, which I will come back to. And actually, one of his relatives, Melvyn Bragg, also studied at the school and also went up to Oxford. I went up to Oxford in 1990 to study medicine and physiological sciences. Probably one of the lesser known colleges, Teddy Hall or St Edmund Hall, and had a fantastic experience there, very, very different from the rural upbringing that I'd had. I then spent my time at various teaching hospitals. I was a houseman at the John Radcliffe in Oxford, a houseman in Newcastle at the RVI, and spent a couple of very good years in London on rotation. And one of the main hospitals I worked at was the Chelsea and Westminster Hospital, which was actually where my interest in oncology started. I was doing HIV. This was just at about the time when antiretroviral drugs were introduced and were beginning to work, and increasingly we were seeing cancers in patients with HIV. And at about the same time as that, my father became fairly unwell, and I wanted to move back up to the north. So I asked my mum, do you know any hospitals in the north of England? And she said, well, to be honest, the only one I've heard of, which is any cop, is the Christie. And so I applied to Christie and was successful, and started there here as a junior in 1999. And despite trying to leave a couple of times, I've never left. I got my consultancy in 2007. Initially, I practiced in pediatrics and lymphoma. The latter I gave up a few years ago to focus more on the pediatric and proton side. It was really about that time conversations were really starting around the use of proton therapy to treat children and others. And there were a few notable cases at the time where one family, Asher King's family, went off to Prague for proton therapy, which was caused quite a bit of discussion in the news. And there were other notable cases at the time. So what are the clinical benefits of proton therapy? Well, essentially, it's a form of radiation therapy. Historically, we have used conventional radiotherapy with X-rays. The key here really is no exit dose past the target that you want to treat. And this has some advantages, particularly in children and teenagers, where the aim there is to reduce the risk of longer-term side effects. But it can also be used in some adult cancers to give more dose than you ordinarily could with photons. And this enables you to give an escalated dose to those tumours. On the right-hand side, anybody in radiation oncology will be familiar with this graph. This shows a comparison between photons and protons. Protons have this particular quality, the Bragg peak after William Bragg, a fellow Cumbrian. And this peak deposits dose. Now that peak is very, very narrow. So what you try and do is you try and spread that out to cover the tumour. So there is the potential to reduce not only the exit dose that you would normally get with photons, but potentially some of the entrance dose as well. And here you can see a sort of a clinical manifestation of that. This is a craniospinal treatment in an older patient. In a younger patient would have attempted to cover the vertebral bodies, but this is an older patient. On the colour wash, you can see on the right-hand side, this is a photon treatment. And the treatment is given from the back. So you can see that exit dose coming out through the thyroid, the heart, the lungs, and bowels, etc. On the left, you can see the proton plan And I think it's quite nicely demonstrated the effect of the proton therapy there on the spine, on the MRI scan, on the right-hand side, where you can see the bone marrow changes, which reflect comfortingly where the radiation you wanted to deliver it to. There's actually been an NHS programme for some time, since 2008, and because there were no high energy facilities in the UK, there's a low energy facility at Clatterbridge, but no high energy ones. Patients were referred abroad, and a number of centres have provided that service over time. The introduction of this overseas programme came alongside a commitment by David Cameron at the time to establish a service in England. So what are the benefits of treating patients in the UK? Well, it's great if you don't have to travel abroad for treatment. So bringing them to the UK, this would improve access, meet any unmet need, reduce the cost per patient, so you could treat more patients. And also importantly at that time, I mean, with sending patients abroad, we're not treating them here in the UK, so it prevented de-skilling would prevent de-skilling to a certain extent. There are also other advantages. You increase your capacity. There is certainly something around excellence by treating a high volume of rare tumours on one site. You become a hub of expertise, and you also have a halo effect on surgery and other pathways, which is really important. And obviously you can leverage the research opportunities of having a service on UK soil, whether that be technical, clinical, or around real world data, which has really become my interest. On the right hand side, you'll see some of the standard indications for proton therapy, which have increased over time. So what was the approach to UK PBT provision? Well, there were two centres selected, Manchester and London, to serve the UK, and latterly we've been providing a service to the Republic of Ireland with 250 million in public dividend capital. The whole programme has a revenue of around 40 million approx, and that's both the overseas programme and the UK programme. And very much the tumours and the patients that you want to treat and the associated pathways really do influence service provision and indeed the selection of centres in the first place. So from a technological point of view, we knew that we would need multiple gantries, which is where we treat patients to cater for the volume of patients that we wanted to treat. Advanced imaging capabilities, and also we wanted the latest proton therapy technology, which was scanning technology. Historically, many patients were treated with an approach called passive scattering, and I think, you know, our endeavours to set up a proton service came along at just the right time as scanning technology matured. And there's all the other things that you would hope that would support patients. So, you know, experienced colleagues, making sure that you've got the integrated services to meet their needs, whether that be paediatric, teenage, young adult, etc., etc. It is also an opportunity for, given that it's a new modality, for real world data outcome tracking, and that's something that was a very significant consideration for us, which I'll come on to. And also having a research infrastructure. On the right hand side, you will see these are travel isochrones. So the hotter it gets, the closer to a proton centre you are. And given that most of the population lives along both the M62 corridor and also essentially a line from Manchester down to London, many patients, it was felt that the location of these centres would benefit the most patients. We were very keen, I was very keen that the service was an integrated one with service, research, clinical outcomes and education as pillars of the service, and each of them of importance. An endeavour such as this does not happen overnight. I guess sort of my involvement was by virtue of the fact that I was doing paediatric radiation oncology at the time, so I was in the right place at the right time to take this forward as clinical lead with my colleagues. So, you know, we didn't actually get the business cases and the approvals really until around 2015, 2016. And the procurement process was the largest radiation therapy procurement in the UK. It was very interesting to be a part of. But most of the time, I just listened to my physics colleagues on that front and took their advice. We successfully opened in December of 2018. And although we're not quite at full capacity, this was a projection from the time, we are seeing our numbers increase month on month and year on year, especially with the opening of new clinical trials and other new indications. So that is the Proton Centre on the left there. It is essentially over 4 floors with a very nice entrance, and we have a school there for children. On level 1 is where pretty much where a lot of the magic happens for the patient, where they will have their preparatory scans and then go on through for treatment. Level 2 is clinic space, and where the clinicians, or a lot of the clinicians and physicists are based, and level 3 is admin. And Karen's group actually is located up there also. So this is just an overview of floor 1. Which is where, as I said, the pre-treatment imaging, immobilization, and the treatment would happen. As you'd expect, given a lot of our patients would be children, we have a large section devoted to children and anesthetics, because young patients can't necessarily lie still for 30, 40, 50 minutes. And so anesthesia is a huge component of our service. The centre is light and airy. It is above ground, which is great for patients and also for staff as well. We're a 3 gantry facilities, you can see in the top left there, with a cyclotron producing the protons, which then goes into the gantries to treat the patients. The 4th room there is where Karen and her team do a huge amount in terms of research, and I'll come back to that later. This is the treatment room itself, very Star Trek-y. They are lovely treatment rooms, very calming for patients. So we've treated a fair few patients since we opened in December, and we should be just about at the time where we're treating our 1,000th patient. I've not had an update on that recently, but as you can see there, it has been a lot of work and very enjoyable for all concerned, helping those patients. What about the programme overall? Well, the number of patients receiving proton therapy has increased year on year, and you can see the impact there of the Christie opening in 2018, where we saw quite a surge, and that was probably meeting unmet needs. Some patients are not well enough to travel abroad for their treatment, or the timelines don't work out to sort of fit in other treatments they may need. So we did see quite a surge there. COVID, of course, impacted the service, but I'm very proud to say that, you know, as a service, we pulled together. The overseas programme basically stopped for over a year, and we were able to treat all those patients at most need. And I think I will always remember that as a very, very successful time for the service. UCLH ultimately came and joined us in 2021. At the present time, coming forward to 2023, the overseas programme is now closed, and both services in the UK are treating patients. An important aspect of the service, and something that I've been closely involved with, has been the development of Proton clinical trials. This has been a national sport, and many of the chief investigators are from trusts other than UCLH at the Christie. We have Torpedo open at the present time, and we're very nearly up to target accrual with that. We've also opened the Parable study, which is a breast study, and the Christie is now open for that. So both of those are recruiting very well. It's important to say that a big aspect of our service is devoted to clinical trials and evaluative commissioning studies, which I will touch upon. The collaboration and the integration of research into the service has been absolutely fantastic to see. Both Karen and myself are co-leads of the Proton stream and the advanced radiotherapy theme of BRC2, but working together on the real world data aspects, wearables, and perhaps developing tools to share some of the decision making with patients and more involved in their care, I think are big headline things for the service and the way we've approached that integration. Outcomes has been a huge feature, and it was thought about even before the service opened. Fundamentally, we developed digital systems that not only supported care, but collected data from referral right through to long-term follow-up, whether that be clinician-reported data or patient-reported outcomes. And we have a standard minimum data set across both providers, and both providers are furnished with Proton clinical outcomes units to curate, quality assure, and provide some analytic support to us. It also democratizes access across the service and to researchers also. There have been multiple outputs, and it would take me too long to go through them. There are some examples there and some example topic areas on the left, but the work we've been doing off the back of not only outcomes but other aspects of service has been wide-ranging. Education has been another focus of the service. We have a Christie Proton School, which is now virtual. It's always very well attended, and that goes from strength to strength, and we look to build on that. Also, we have observerships and fellowships that we offer. That is a tripartite endeavour with the Christie School of Oncology, the University of Manchester, and ourselves. So what about the future? Well, really, we're active in all of these four areas, but I'm going to concentrate on the first three. Increasing the indications, there are many ways one can do that through formal Proton clinical trials. Another method of doing that is through the development of pre-commissioning or commissioning through evaluation studies, which is an NHS way of providing evidence. There are many situations, especially with rare tumours, where either the number of patients or there wouldn't be equipoise if you did a randomised clinical trial where you feel patients might benefit from receiving proton therapy. There are many in development. These are the first four that we are actively development. The important thing to note here is that the Christie is leading on the implementation of these studies, and the Christie is providing sponsorship. And given the nature of the protocol that's been developed, I'm the CI for all of those studies, but there are work stream leads and investigators for each of these, and we do hope to open our first one in the next few months. Proton clinical trials, I showed you two that are active. There is a number of trials across many disease groups that are also in active setup at the moment, the majority of them on a national basis, some of them just at the Christie. I think one of the sort of the flagship things for me is the development of an NHS Proton Registry at the Christie. We've received funding to develop that, and ultimately we will leverage that to deliver the evaluative commissioning studies. Another important thing to note here is that for every Proton clinical trial that opens, we have data sharing agreements in place with them, so that data isn't just siloed in the sort of trial offices. It can actually be secondarily used for outcome analysis, and ultimately all of that data from both Christie and UCLH would be uploaded to the NHS Proton Registry, and we're going through the procurement on that at the moment, and I'm the clinical lead for that project. And that will come with additional analytic resource, as well as a rolling clinical PhD funded by NHS England. So that has been a whistle-stop tour through protons, both past and present, and I think it's really important for me to acknowledge the many people I've met and worked with along the way. First and foremost, my family, who encouraged me to actually get an education and leave Cumberland, as it was then and soon will be. My parents were absolutely amazing and gave me the greatest of childhoods, and my brother and sister, and my old faithful Reg, who is still with us but knocking on in years. Of course, protons really wouldn't have happened with sort of the giants before us, really, and Ernest Rutherford discovered the proton in Manchester at that then Victoria University, and William Henry Bragg, of course, my compatriot, who described the Bragg peak and the nature of how protons interact with materials. From a project point of view, Sir Adrian Crellin is the national lead for protons, and has been a huge support for me over the many years. And the project team itself, Nick Slevin, who is now retired, was absolutely instrumental as SRO in sort of navigating much of the process. And Rand Mackay, looking a little bit younger there, Professor Rand Mackay, my colleague in physics, and we went lots of places together. I think that visit was to Shanghai. Yes, that was to Shanghai, and I haven't talked about all the travel that was involved with protons, with the proton development. And you can see there on the right Hazel Pennington, who was the for a substantial part of the project, the radiographer lead, and all of those working together, we wouldn't have got to where we are today. On the bottom, we've got Yen Chang. She is the clinical lead for protons down at UCLH, my proton wife, who I have spoken to on a weekly basis pretty much for the last 10 years. And of course, Karen, who joined us to lead up the research aspects with the Precise group, has been a fantastic colleague, and we work very, very well together. And of course, my friends, as well as all my colleagues in Manchester, the wider UK and internationally. So thank you very much for your time.
Thank you, Ed. If you can just stop sharing your screen. Yeah, fantastic, I think, to hear an overview of your career. Particularly, I think those hints of the next steps in the Biomedical Research Centre, with that kind of integration piece and data and digital and wearables. And I think there you touched on all the aspects that we're recognised for as an HSC, so that excellence in research, excellence in education, and excellence in patient care. So thank you very much for that. We will return to questions at the end. But now I'll hand over to Joe Hart, Professor Joe Hart, who's the head of the Division of Medical Education in the faculty, to introduce Professor Iain Lawrie.
Good afternoon, everyone. I'm delighted to introduce Professor Iain Lawrie. Iain has balanced clinical roles, research, education, and excelled in each, including leading the palliative care team at North Manchester across all of his many other roles, based at Manchester University's Foundation Trust, formerly Pennine, for 15 years. During that time, he's really led the transformation of that service, impacted on many others nationally and internationally. Locally and nationally, he's worked to challenge norms and push boundaries to improve patient experience. The work by Iain and his team has been recognised by many awards, and the service has been rated as outstanding by the CQC. I can see how his interdisciplinary approach has enabled teams to work together to enhance patient experience, valuing all of their respective professional expertise. It's notable that during his tenure in national leadership of palliative medicine, he opened up membership of that organisation to non-medics, demonstrating how he values all of his colleagues. Iain's work during the pandemic is particularly singled out by his colleagues. As a national leader, president of the Association of Palliative Medicine, at an incredibly tough time, he was able to lead and support policy, advise and be there for clinicians who are facing really difficult decisions. Iain is an expert and a leader in education. He's an Associate Hospital Dean for Communication Skills, has been Undergraduate Director of Medical Education and does a significant amount of teaching. He's an inspirational and student-centred teacher. His significant illness session for the undergraduate medical students here in Manchester really stands out to me. It's a session that makes students stop and think. Iain is one of my favourite colleagues, and not just because his hugs are so good. He's known for his collegiality, humanity, humility and warmth. His significant expertise adds so much to what we do. Personally, I've been able to see his compassion and skill and that of his team when my aunt was at the end of her life in the community in North Manchester. I saw the humanity and care they took in supporting her and our family, as well as really practical support, truly holistic care. One of Iain's referees, when he applied for the MAHSC Honorary Clinical Chair, said, "Manchester is lucky to have him." I totally agree. Over to you, Iain.
Thank you very much, and thank you for the reference to Auntie Joan, never to be forgotten. I'll just share my screen now. Excellent. Hopefully everyone can see that now. Yeah, thank you for those very kind words. I share Ed's statements and echo them that I do a lot of teaching every year, a lot of presentations, and as everyone will say, I do a lot of talking, but actually I'm nervous and this was very difficult to prepare. As often happens, though, I follow the oncologists, so it was the right order to do things in today. When I was thinking about what should I actually talk about today, it suddenly struck me that one of the things that people say to me most often is your work must be really sad. And they often say it with that kind of tone of voice. And then they usually follow up, because all your patients die. I'd like to talk about that a little bit today and possibly dispel some myths. So when you're appointed to an honorary clinical chair, you get that email and letter, you suddenly panic. How the heck did I even get here? How do I deserve this? What does it mean? Do I have to change what I'm doing? Are people going to expect that I know things when I've maybe been blagging it all my life? Do I have to start to wear a tie again or get a professorial affectation like a, I don't know, like a waistcoat or a monocle or something like that? All these stupid questions go through your mind. But my family are really proud. My mum, my dad, my sister and husband, my nephews, my husband himself, they're all really proud of me, and I would never have got to where I am today without their love, support, and mum and dad financial support has to be mentioned there as well. So back in the mists of time, I come from a small town called Carluke in Lanarkshire, population about 25,000, famous for having 3 Victoria Cross awardees, is that the right word? But possibly more famous for having Scott's Jam Factory. The Clyde Valley in Lanarkshire is a big place for soft fruits, strawberries, raspberries, etc. And we used to go fruit picking during the summer. And 200 yards from my mum and dad's house is where they make the jam and the Scott block chocolate. I had to put in a little picture of when I used to be cute as a little boy, and I have to point out you can age the slide by the fact that my dad's wearing socks and sandals there. I enjoyed school. I was very active in Scouts, in terms of Cubs, Cubs, Scouts, Venture Scouts, and being a leader. Gained the Queen Scouts Award. But I suppose my interest in healthcare came when I took a first aid course with the St Andrews Ambulance Association, akin to the St John's Ambulance Association down in England. And went on regular duty with them. And I think it might be a bit odd that I was always really disappointed if I'd been to a gathering, an event, a pantomime, or whatever it was for the St Andrews Ambulance, and nobody took ill or was injured. I was often disappointed by that because I wanted to show my skills. I then followed my sister's footsteps into physiotherapy at the Queen's College in Glasgow, and that is me graduating there with the blue sash on. Thankfully, my hair doesn't take as much time to do in the morning. My sister was an exemplary student and did very well. I don't know if I quite did her justice following after her. I then moved to Canada as a physiotherapist, and became an intensive care physiotherapist. And what used to happen in the morning was the junior doctors would come in, they would ask me about the patient, and I would tell them their observations, how they were doing, the ventilator settings, and my recommendations. Then the consultant would arrive, and they would repeat what I'd said to the consultant. So I thought, if they can do it, I can. And that's when I decided to apply for medical school. So it's always an epic journey. I've mentioned physiotherapy. I then went to Leicester Medical School between 92 and 97 and continued to work as a physiotherapist, usually every other weekend and at least one night on call during the week. I became a house officer in Leicester and then went off to Mackay Base Hospital in Australia. They've got a lovely new building now, but that was real in the back of beyond medicine with 2 doctors for a 300-bed hospital overnight. So I learned an awful lot there. Came back to the UK to do GP training and actually dropped out of the regular programme because it was a bit restrictive and went off to do other standalone jobs, which I think are really important for medical education, but less available to people now. I have to qualify the fact that I had spent some time in prison. I went for my specialty training interview, and one of the panel members said to me, there seems to be some gap in your CV here. I can't quite tell what you were doing. And I said, oh, I was in a category B lifer unit, at which point everyone put down their pens and stopped talking. And then I quickly said, oh, I was working there as a doctor. I wasn't an inmate. And there was a lot of relief on their faces. Whether that got me into my specialty training, I do not know. But the fact that I've done all this, I feel is great experience, especially when, as a palliative medicine physician, no 2 days are the same. You're seeing a broad spectrum of society. You're seeing lots of different conditions. And I think my epic journey to get to palliative medicine is probably appropriate for me. So palliative medicine, my first job was in Loros, the hospice for Leicestershire, and I have to single out Professor Mary Lloyd-Williams as being the person who encouraged me, coaxed me, tutored me, mentored me to go into the specialty. I eventually arrived at North Manchester General Hospital in 2008, and I found my family. I don't know if any of you have ever been up to North Manchester General Hospital, 150 years old, although a lot of it's being knocked down and rebuilt at the moment. But it is a wonderful family community of staff to look after patients. And the Trust has supported me to explore other avenues in my career, such as being vice president and then president of the Association for Palliative Medicine in the country, and for being a trustee, councillor and various other things with the Royal College of Physicians. Not name dropping here, but Laura Finlay, Baroness Finlay is a palliative care consultant from Wales who has been hugely instrumental in my career, providing me with advice, ticking me off where needed, and steering me on the right path, as well as Professor Derek Willis as well. But I have to thank my friends at the university and the trust and beyond. So what is palliative medicine? My slides are less technical than Ed's because he uses fancy Star Trek machines, and unfortunately in palliative medicine I don't have fancy Star Trek machines. What it is the active total care of patients. I hate to think of palliative care as being the end. There's nothing more we can do, or passive. It is not. It is the active care of patients in terms of actively treating symptoms, of managing psychological issues, of trying to support social issues, etc. And total care, I'm going to mention, total care is the physical, social, psychological and spiritual. And by spiritual, I don't just mean religious, I mean all the existential questions. In that palliative care treats complex situations, and attention to one area, such as physical symptoms, means you'll fail. People don't come with compartmentalized physical, social, psychological and spiritual issues. They all come as one, and you really have to address them. Palliative medicine's not all about death and dying, though. It did start that way. It started very cancer focused, and it was end of life care. These days, palliative care, some months I see 50% of patients who don't have cancer. So it could be lung disease and heart disease, kidney disease, neurological disease. So it's not all about cancer. It's also not all about death and dying, because we can be involved right from diagnosis with patients who may be going for a curative option for treatment, but have symptoms or complex issues at the time. So that's one of the things I want to do, is to dispel the myths about palliative medicine. So is palliative medicine sad and depressing? Not always, but I have to say, okay, yes, sometimes it is. We're supporting patients through treatment, but we're focusing on quality of life, helping people to live as long as they can, as well as they can. If people are approaching the end of their life, trying to achieve a good death. And that might sound odd to people, but a death can be good if it's got comfort and dignity with the people around you that you know and love, in a place of your choosing. As I mentioned, we get involved in very complex care often. And I often say that people bring me a big pile of poo and ask me to sort it out in terms of a clinical situation. Probably the only inaugural lecture to mention the word poo, but hey, there you go. But we do good things too. We do happy things. We have weddings. We have 2 or 3 weddings a year at our hospital. People who maybe have been together for years, but when they're approaching the end of their life, think they really want to get married. And that's a joyous thing for us to do. We've also had a couple of babies during my 15 years or so at the hospital. People with cancer who, I was going to say unexpectedly get pregnant, but it only takes once for it to happen, doesn't it? So we have teen babies as well. I mentioned pets, and I'm often thinking of my patient June from a number of years ago, who had significant uncontrolled pain that we were really struggling to manage, and a lot of agitation and anxiety. And when we dug down into it, what she was actually worried about was her pet parrot. So my technical complex intervention was to ask my colleagues in the Macmillan Information Centre to look into this for me, and found a charity that adopts pets in this sort of situation. June's pain decreased, her agitation decreased, and she had a really comfortable death. So it shows you that not only the physical, not only the medicine, is really important. We need to put people at the heart of care. We need to put the staff at the heart of care, the patients at the heart of care, and those close to them at the heart of care. So at present, what interests me and motivates me, empathy and compassion. I really want to develop that with our undergraduate medical students, and we're doing that through our significant illness sessions and our communication skills teaching sessions. I don't want mediocre care. I want gold standard care. And even in an environment like North Manchester General Hospital, which isn't state of the art in many respects, we can provide gold standard care, and I will challenge mediocrity, and the staff that work with me know that. Education is a huge part of my work. Obviously, there aren't enough palliative care physicians, palliative care nurses, etc., to provide palliative care to every patient. So we have to educate our colleagues in providing what is normally needed in palliative care, reserving ourselves for the complex. I want to increase awareness of the fact that we all die at some point, and that planning ahead at any point during the different milestones of your life is very important. Really key to my heart, especially during the pandemic, has been supporting colleagues. I think I've got possibly as an Amazon record for buying 70 odd kilos of little packets of love hearts during the pandemic. And what we did when we didn't have our usual population coming into the hospital was go around and obviously see patients who were exceptionally ill, but give out love hearts, stop and talk to staff, see how they're doing. And that is a really important part of work on an ongoing basis. I like to be honest, and we all should be, but I like to be honest with my patients. If there's uncertainty, I share the uncertainty with them. If there is certainty, if they want it, I'll share that with them. The information we receive as clinicians isn't our own, it's the patients, and we all should be honest. And with the bereavement office, our fantastic bereavement clinical nurse specialist, and our wonderful medical examiner office at North Manchester, I want to improve the bereavement care for all of those close to the patients who die at our hospital. So my mantra is, being polite and friendly costs absolutely nothing, and we should all be doing it. Do one good thing every day, whether it's directing someone that looks lost in the corridor, whether it's making someone a cup of tea, whether it's just asking someone how they are. That's vital. And as I've learned over 15 years at North Manchester General Hospital, be very flexible and think outside the box. So nothing is certain but death and taxes, I've said. I think I've mentioned that palliative and end-of-life care is everyone's job, not just the experts. You don't need to be an expert. And that care and compassion over the medicalisation of death is vital. I want to bring death, dying and talking about it back into public consciousness. It's a natural piece of life, and we become a natural part of life, and we possibly become frightened of talking about it. So the future, better funding and recognition for palliative care. There are only 217 hospices in England, so only a couple of thousand beds. There are about 700 consultants in palliative medicine in the country, but palliative care isn't a nice extra. It's been proven to be cost effective. It's the right thing to do. And if we don't care for people at the end of their lives properly, what are we doing? I've mentioned awareness and dispelling myths about palliative care. It's not all cancer, it's not all end of life, and getting people to think throughout their lives about what's important to them, what would they want, and what wouldn't they want. And the future for me is retirement in the near future-ish, you never know, or maybe just cutting down a bit. To finish, life outside medicine. I live up in Davenport, very happy in the Manchester area, but Scotland and the Outer Hebrides are very close to my heart too. My husband Mark looks after me a lot, gives me a kick up the bum when I need it, and encourages me throughout my career. My family and friends, mom and dad are there, my great nephew are there, but all my family and friends are very important to me, as are gardening, reading and eating, not necessarily in that order. Thank you very much.
Thank you, Iain, for that. That was a fascinating overview, I think, of your career, and I think a specialty that people can find it difficult to talk about. But I think what you've shown is that it is that, you know, that physical, social, psychological and spiritual holistic patient care that I think is at the centre of all of the work we do. So thank you very much for that. So I'll now open up for questions if there are any. You can post them in the chat or raise your hand. So are there questions for Ed or Iain? Karen, can I come to you if you've got any questions for Ed?
Yes, I was going to, well, first of all, I'd say 2 fantastic talks. Thank you both so much. But going to Ed, with the Proton Clinical Outcomes unit, you managed to persuade your colleagues to do something they'd never done before. Would you like to tell us a bit more about that?
Crikey. I don't know how much influence I've got. I suppose historically in medicine, we're very much used to writing notes rather than directly inputting into a screen, and referrals to, you know, as an example, have tended to be, you know, a dictated letter and a couple of results attached to them, rather than sort of a minimum data set of what we need to know, and then being able to use that data in the future for looking at the process, the pathways, as well as using that for clinical outcomes analysis. So I suppose the biggest transition for colleagues and myself, we've always had a fairly decent electronic health record at the Christie, but actually being essentially paperless in that regard, I think it was a huge change, and actually takes a bit more time than just dictation, but hopefully you get some of that time back in the future, because everything is stored in the same place, and you know where to find it, hopefully. And actually, you know, you benefit in other ways, because you can look at cohorts of patients and see how they've fared, and interrogated that cohort of patients to see which particular groups do well, which particular groups don't do so well. So hopefully there are advantages from that colleagues appreciate. But that was a big change, and actually having the national referral portal was just the start of that sort of electronic data capture journey, really, for colleagues. But I think we've shown it can be done, but you've got to have enough time to do it. And if I had my time again, I would perhaps have simplified it. But you know, we have an opportunity. We've got an upgrade to our electronic health records, so that is an opportunity to simplify things. So hopefully the burden will get less rather than more.
If I ask you one more question, which is, I know people come from all around the world to find out how you put together a clinical service, and you know how you manage to do it so much on time and, as I said earlier, below budget. But if you had to give 3 pieces of advice to someone coming to you on how to develop a clinical service in proton therapy, what would those 3 things be?
Oh, crikey. Well, it depends very much on their case mix. I have been asked this question. There's a development going on in Eastern Europe at the moment, and I've been sort of in discussion about that. I think it depends very much on the case mix. Firstly, I would say is having a facility integrated with a hospital, with all the services you need pertinent to that case mix, is absolutely key. The second thing I would say is that the voice of all stakeholders is important, whether that's physics, clinical, radiographic, patients, to actually define what you want your service to achieve. That's the second thing. And thirdly, I would say don't be scared of proton therapy. There are a lot of similarities with conventional radiation therapy. It's about identifying those things that are different and that you need to address and take account of, but there are a lot of similarities. And if I can add a fourth, visit lots of centres. That's what we did. Ran, myself, many others, did a little bit of a tour. Fortunately, most of the centres are in the US and some in Asia too. Find out what they do, what's their practice, what are the big problems they find, and then take a considered opinion for your own health economy, because the NHS is quite unique, and we were able to address some issues that perhaps other health economies were not able to. Yeah, that's my 4.
Thank you. And Joe, do you have any question for Iain or indeed for Ed?
Yeah, I mean, thank you, Ed, Andy, and as I said at the beginning, I think we're very, very lucky to have you both associated with our university and more generally in Greater Manchester, and staggering to think about the impact you've had on both of you on people's lives and deaths over those many years. I was going to ask Iain about something you mentioned a couple of times, which was about public consciousness and awareness raising, and that strikes me as really important and a really big task, and people are understandably worried about end-of-life care and some of the terms like palliative medicine and the pathways. How do we start on that? What's the grand plan?
Well, I think the term pathway, and for those of you who might not be aware, that we used to have the Liverpool Care Pathway, which was a really well thought out model